With the experience and resources for cases throughout Louisiana, Walters Papillon Thomas Collins, LLC, is proud to support LPB, specializing in personal injury and wrongful death, with information at lawbr.net.
I am generally a neurosurgeon, but I have done an extra fellowship in a specialty called skull base neurosurgery, specifically focusing on tumors. There's actually a couple of different forms of skull base surgeon that we'll talk about in a second. If you have any questions about anything, feel free to interrupt. We're used to it in neurosurgery as well as in medicine in general. Usually it's less malignant. They're much more malignant than this crowd, I'm sure. So this is an overview of where we're going today. First, pretty much already done an introduction. The first question I'm going to answer is, what exactly is the skull base? There's a lot of anatomy involved. Then, calling Baton Rouge, we've got a problem. One of the things that we look for to be a problem in the skull base that we treat as neurosurgeons. I need a hero. We need somebody who's going to treat it for us. Cracking the egg, that's what I like to call it when we actually do surgery on the skull. Sorry. And then if you have some questions at the end, I call that the shooting gallery. Now you've got my sense of humor. So. All right, so pretty much everything that we've already talked about. The one final piece that I would add already is that I am waiting final approval from the AOA for my certification, but all of my board certification exams have been completed, which makes me a full practicing neurosurgeon with a skull-based tumor specialty. We are at the Baton Rouge General. I am a two-lane physician. My partner, Dr. McAllister, is also there. My physician's assistant and office manager are my guests today. They're over there. They're both fantastic. Let's see. So, what is the skull base? Moving right into it. The short of it is that if I could unscrew the top of your head and remove your brain, it would be the undersurface of the brain and the inside of the skull there. Okay, so it's basically everything above your eyes, behind your throat, and in the low part of your neck, or low part of your head, just above your neck. Okay, I'm going to illustrate this with some pictures. I like visuals, so we're going to do that in a minute. This area includes a lot of what I like to refer to as high-price real estate. Okay? So that is all of your major arteries, including where the carotid artery from your neck comes in and becomes the intracranial carotid, the anterior cerebral artery, which is the front part of the brain, the middle cerebral artery, which is the main artery that you think of when a person has a stroke, the posterior cerebral artery, the circle of Willis, which is something, an important thing to vascular neurosurgeons, and including all of the cranial nerves. The cranial nerves basically govern the function of all the senses in the face. So smell, sight, movement of the eyes, sensation in the face, movement of the muscles of the face, taste, swallowing, and a lot of your visceral organs are controlled by all of that part. Okay? So a lot of important structures, including all of the venous sinuses, and what we call the CSF, or cerebrospinal fluid cisterns, which is basically the pools of the fluid that your brain and your spinal cord is bathed in, which carries all the nutrients that your brain runs off of. Also, it's all of the holes that our nerves and blood vessels protrude through, which we call foramen, and other various apertures and structures that are important to the communication with the outside world. As I said, I like visuals, so here's starting with the bones that make up the skull. We have the frontal bones, which is in blue there, the parietal bones in green, and the occipital bone in orange. They all go together to form what is essentially the base of the skull, which you see on the right over here. All of that. There's all of the major foramen through which the nerves and major blood vessels go through, and of course what we call the foramen magnum, because we like Latin, it just means big hole, and that's the one that the spinal cord goes through. Doctors are simple people. It may not seem like it, that's why we had to throw it in Latin, but otherwise we're simple people. Speaking of, if I could remove the brain and look at the undersurface of it, the image on the left is your brain from the side, which includes the frontal lobe, the temporal lobe, the parietal lobe, the occipital lobe, and the cerebellum. as well as the brain stem. Looking at the undersurface, you can see this yellow projection right here is actually the olfactory nerve. Then they're removed here, but the optic nerves are at that ridge right there called the optic chiasm. The mammillary bodies and pituitary stalk here, what's called the pons, and the medulla, the brainstem, and the undersurfaces of all of the brain lobes, and all of the cerebral arteries, including the one I alluded to already called the MCA, or middle cerebral artery, and this structure here around the base, which is called the circle of Willis. Okay? Questions about any of that? No quiz at the end, I'm sure. I need to know it, you don't necessarily, but I do visual. So, calling that rouge, we have a problem with the diseases of the skull base that we as neurosurgeons focus on. The main one that I like to talk about, which is the one where most of my training was, are of tumors. This includes benign tumors such as meningiomas. We can have those anywhere along the skull base. The meningioma, as the name suggests by the root word meninges, the meninges are the covering of the brain. An oma is a tumor, so it is a tumor of the covering of the brain. Generally speaking, those are benign. About 92% of the time they are. The remaining 8% can be of higher histologic or cancerous potential, but generally speaking, the meningiomas are benign tumors. Also, pituitary adenomas, which are generally speaking benign tumors of the pituitary gland. There can be cancerous tumors of the pituitary gland as well. The pituitary tumors are divided into those that are sort of just a structural tumor that has no function, and those that have hormonal function associated with them, which we'll talk more about later on. Additionally, there's something called a craniopharyngioma, which is more commonly a problem in children. It's a congenital tumor that's very complex. I'm going to show a picture of that in just a second. Don't worry, it's just an MRI, it's not a gross. Optic gliomas. Gliomas are high-grade tumors. This can be of the optic nerve. Vestibular schwannomas or acoustic neuromas, depending on the technology, the naming convention that people are used to. Those are tumors essentially of the inner ear that project in the low part of the skull base in the back. Cholesteatomas, which is another one in that region. Chordomas, which is of the solid portion of the lower part of the skull of the clivus, and a couple of other various forms of tumors, but those are your high elements. We also have vascular anomalies. A skull-based surgeon with more cerebrovascular training would treat. That includes aneurysms, arteriovenous malformations, fistulas, thromboses, etc. One of the other things that we as skull-based surgeons, whether we're vascular or tumor, treat are defects of the skull base. These can be due to traumatic injuries. They can also be spontaneous, particularly if a person has a disorder that causes them to have excess spinal fluid or increased pressure inside of their brain. The most common of those is called pseudotumor cerebri. That's the older term for it. The more modern term that everybody is trying to get us to use that nobody wants to use because nobody knows what it is called IIH, idiopathic intracranial hypertension, which just means we don't know why it happens, and it's high extra pressure basically inside the skull. And then a number of other congenital anomalies, something called a Rathke's cleft cyst, and Chiari malformations, which really are outside of the scope of specifics of this talk right now. So, just to illustrate, this is actually an illustration that I lovingly lifted with permission from my friends at the Cleveland Clinic. This is to illustrate where the pituitary gland is. It's actually a small projection off the base of the brain itself into a small notch of bone called the sella turcica, which means Turkish saddle. If you Google Turkish saddle, you see that it has a very U shape to it. The sella turcica has a U shape. It separates actually the pituitary from the rest of the skull because there's a dura or leathery covering over the top of it called the diaphragma cella. On the right side of this is actually an illustration of what happens when you have a large pituitary tumor. It's called pituitary macroadenoma. It actually warps the shape of the cella turcica, and it can invade intracranially, meaning come into the cranial space itself. As you might imagine, as I've already illustrated, that can be problematic. There's a lot of important structures that are right over top of that, including what's called the optic chiasm, which is the most important part. It's the bridge of tissue that joins your optic nerves together and projects them out to your eyes, essentially. The most common way that this presents is a person actually is seen with some loss of vision in what's called the peripheral vision, the temporal vision. We won't go into the neuroanatomy of that specifically, but it is bitemporal hemianopsia is what's normally the phrase, and it's essentially loss of peripheral vision. So a person will come in complaining of headaches, and I was driving my car and I hit 3 parked cars. I didn't even know they were there. So usually it comes in as an ophthalmologic referral, potentially. You say, well, how can a person not know they have this giant goober? It's because that area is insensate, essentially. It's more common for them to be found a little bit smaller when a person has hormonal issues, because sometimes the cells that are abnormal in this particular tumor can grow from a cell that produces hormone. So the most common of that is something called prolactinoma. The hormone prolactin is hyperproduced. Typical presentation is a person who has a loss of libido, depression, weight gain, things like that, which can be very high. It can be very hard to diagnose because obviously that sounds like a person that's depressed. So sometimes it has to be a high degree of clinical suspicion on the part of an endocrinologist and a very astute internal medicine or family practice doctor. Prolactinomas have a unique distinction that they are most commonly not treated by surgery but with medication, which is why I know it, because it's usually one I don't necessarily treat, but an endocrinologist would. Here's an MRI example, both looking at on the left what's called a coronal cut, which is like if we take your head and slice it like a loaf of bread. That's a coronal cut in the MRI, so it's like looking at you face on. The one on the right is what's called a sagittal image, meaning basically cut your head like this and split it open and look at the atoms. It's the same as the illustration we've already looked at, just an actual patient, again, lovingly lifted from Google Images. All over the references are at the bottom if you want to those and see the articles are attached. There are some very important structures also on either side of the cella turcica. That area that's contained there is what's called the cavernous sinus. This is a large venous sinus on either side of the cella turcica. This contains a couple of the nerves that control movement and sensation of the eye, movement of the eyes and sensation in the face, as well as the carotid artery. And the carotid artery, as you know, if you're familiar at all, is the major artery that comes off of your aorta in your chest and goes up to your brain. It splits into 2 parts, one that supplies the face and one that supplies your brain. So obviously, that's its entry point. There's a lot of sensitive material in there. So surgery, as you might imagine, is potentially very dangerous. One of the things we worry about with these types of tumors is whether or not these tumors invade into the cavernous sinus. A lot of times it's actually suggested, the MRI and a radiologist will read it and suggest that it is invasive. The interesting thing is that the cavernous sinus is actually very tough. The outer part of it is tough. And these pituitary tumors, although they can get quite large, are actually very soft. So it's unusual, in fact, that they do invade, the exception being if it's actually a cancerous tumor. Usually that's a metastatic tumor. It came from somewhere else. Breast, lung, some other sort of, which is unusual, which can strike some people as odd to think, well, it looks so big, it must be going everywhere. But the nice thing about these things is that they're actually relatively respectful tumors. I mentioned I was going to show a version or an image of the craniopharyngioma. So this is what is a craniopharyngioma. What I'll tell you, looking at this, is these are tumors that have cystic portions, meaning they're fluid-filled, and solid portions. They actually happen to arise from a little piece of tissue that your pituitary hangs off of the brain from, called the pituitary stalk or infundibulum. Consequently, it makes them a little bit difficult to treat, mainly because a lot of times treating them requires you to completely remove the pituitary stalk. We'll talk more about what that means for a person. But these can be very, very difficult tumors to get rid of. They're very adhesive to the local structures and invasive of them. Very frequently, these are diagnosed in childhood. There's what we call a bimodal distribution, meaning that there's an early basically an early time that they're diagnosed and a late time that they're diagnosed. So sometimes even can be diagnosed as they grow slowly over time. These tumors are very difficult, as I said, to stay rid of. They have a very high recurrence rate, even with a successful resection. And the successful total resections are rare. So a lot of times we do treat these with radiation following. This is actually a version of what's called a meningioma. Again, I mentioned that was a benign tumor recovering the brain. This actually arises a little bit anterior to where the pituitary is in what's called the planum, sphenoid, which just means the flat part of the sphenoid bone. And so that's basically what piece right there. So, say you diagnose with one of these problems, somebody is available to treat. There are basically two groups of people that can treat these. Usually this is done in a partnership. One is typically a neurosurgeon, preferably with skull-based fellowship training, because of all the things I've already pointed out to you. This is a place where it's potentially very dangerous. It can be very difficult to remove. However, we as neurosurgeons don't receive a great training on the inside of the nose. And why would that be important? As I'm about to illustrate, there's a couple of different ways we can approach these types of tumors. The more modern way is to actually go through the nose. It's called an endoscopic endonasal approach. I'm going to actually discuss that. So typically I like to, and this is how I was trained at the Cleveland Clinic, I like to work with my ENT partners because they know the nose better than I do. They're more familiar with endoscopic technology than neurosurgeons are, generally speaking, although some neurosurgeons do their own approaches with an endoscope themselves. I like being able to have two different brains, or as many brains as I can get, working on a problem. I think it's better than just going alone, especially since there can be complications with working inside of the nose that we as neurosurgeons don't necessarily know how to manage. So it's nice to have an ENT, preferably rhinology trained, fellowship trained ENT there helping. So, how can we treat some of these skull-based problems? The very traditional way are with what are called open cranial approaches. That basically involves doing what's called a craniotomy, and I'm going to talk about the specifics of that in a minute. The founder of modern neurosurgery's name is Harvey Cushing. Some of you may be familiar with his name, particularly if you've ever heard of Cushing's syndrome, or are familiar with cortisol as a stress hormone in any way. He did this in the early 1900s, in the 1920s, with barely any technology. And he was the first neurosurgeon really to have good success rate with opening these and doing these procedures. So he taught us all. Although on his deathbed, the thing he only said he ever taught anybody was how to close the program. So, also very humble. The endonasal, there used to be the more common way to do these from through the nose was using a large operative microscope. The problem with that is that if you're still operating through the nose, you have a small corridor to use a big microscope to look through. So it's basically if you take your hand like this and you try to look through it, that's your vision. The nice part about what's called an endoscope is it is a fiber optic camera with a light on it that can be given in 4D or 4K, 3D even potentially. So it gives us a giant picture and we can see all the way around. I'm going to show you some pictures of that. I have been trained both in all three of those ways. Although the North American Skull-Base Society will tell you that there is no difference between the outcomes and the ability between a microscopic approach and an endoscopic approach, I will tell you that I've done it both ways, and I think I am a thorough disciple of the endonasal endoscopic way of doing it. So if you can have it done that way, if it is possible to do it that way, do so. Okay? There is another way we can treat these. Usually we do that either instead of surgical treatment or as an adjunct to, and that is by radiation therapy, particularly radiosurgery. So that involves basically high doses of radiation over a short period of time to effectively kill the tumor. A lot of times we do that with recurrences or if there's residual damage. Cracking the egg. All right, I'm not going to spend a whole lot of time on these because they're very technical. However, there are different approaches, and I'm going to show a couple of pictures to the various aspects of the skull base. The anterior skull base, the front part, the lateral skull base, the middle, and the posterior fossa, the posterior skull base, all involve various approaches. The workhorse of the anterior is what's called pituitarial, which is basically a craniotomy right here. The orbitozygomatic is a modification of that involves also taking a portion of the zygomatic bone, the cheekbone, and the bone right over top of it. You can do it by a bicoronal bifrontal approach where we actually flap some of the skin. That is very morbid. You can flap the scalp down anteriorly and open the front part. Or you can have a supraorbital approach that is an eyebrow incision with a small craniotomy. So there are lots of ways that we can do this. Some I didn't mention. We can go across over top of the ear to approach middle fossa issues, or with the help of a neurootologist, which is an ENT that's trained with ears, go translaterally through the mastoid, this large piece of bone. Other way, retrosigmoid and posterior aspect. This is the pterional craniotomy, just illustrating again to labor that, because that's really not the crux of this point. And then this is just showing the various approaches I sort of discussed. Orbitozygomatic allows you a little more range deep in the center. The subtemporal, retrosal or retrosigmoid, and the far lateral, which involves more problems more down low. The endoscopic endonasal approach is really the important thing I wanted to talk about today. So this involves, as I've said, an endoscope, which is a fiber optic camera going through the nose. We have basically the ability to approach the entirety of the skull base, although the corridor can be somewhat narrow. The approaches include the transsphenoidal, the transkrugerform, the extended approach, and the transclival. Illustrating that just a little bit further, basically anything extending from here all the way down to the upper part of the spine, only limited essentially by the inside of the nose. There are three parts. I'm going to go back one slide. There are three parts to an endoscopic endonasal and transsphenoidal approach. There is the approach itself, meaning how we go through the skull, the actual removal of the problem, and then the repair and reconstruction. The workhorse that has radically changed our ability to do this of the repair is something called the basal septal flap. Illustrating that, that's just further illustrating the range of approach we have. Illustrating the nasal septal flap, so the septum is the middle portion of your nose. We essentially remove a piece of tissue, leaving it attached to its blood supply at the back of the nose, and we can put that anywhere along the skull base. The benefit of leaving the blood supply attached is that it reattaches to the skull and becomes a healthy piece of tissue that has its own blood supply. That's really all you need. We don't need to replace a lot of bone. We don't need to put anything else on. If nothing else, putting that piece of mucosa there effectively seals the hole. And it is such a simple invention that 15 years ago, 20 years ago, it did not exist. And these procedures were not as sophisticated as they are, even in the last 10 years. So this really, hats off to my ENT colleague, ENT radiology colleagues, revolutionized our specialty. that's just showing how you can move it and let me move it completely. So this is our endoscopic view. This is actually the defect, and that's brain tissue and major blood vessel back there from a different surgeon's again, just lifted public property that's available. And that is the replacement of the flap covering the bulge. What are the advantages? Obviously, this is less invasive. We're going through this. There's no external scar. There will be potentially some packing left over immediately after the surgery, but again, once that comes out, the swelling goes down. The person hardly ever knows, people hardly ever know which person had surgery. Therefore, faster. And given the fact that we use in some cases, 4K 3D endoscopes, a more complete resection is possible, depending again on how much the tumors involved. Potential complications and disadvantages: you can have a spinal fluid leak, particularly if you have a large hole. Again, nasal septal flap has really revolutionized that. It almost never happens long term anymore. Bleeding, it can cause bleeding of the vascular structures within nearby. Again, this is usually short-lived. We also have a lot of horror stories about how to repair those, so we all know how to do it. Neurologic deficits, but again, whether you approach open or closed, that's the same. The main thing that we worry about, and I'll skip ahead one, is pituitary dysfunction. This can be anything to a short-lived, what we call diabetes insipidus. Diabetes, everybody associates with diabetes mellitus. The diabetes root word has nothing to do with sugar. It actually has to do with the way that we discovered diabetes mellitus, was that we noticed that patients who have excess sugar urinate. So actually the diabetes has to do with excess urination. And what actually happens in insipidus is the antidiuretic hormone, which is a hormone that pituitary produces to control your kidneys, isn't being produced. And so your kidneys do what they're supposed to do. They drink fluid. And what happens is you dehydrate. And you have to replace that with what's called mediated feed or vasopressin. Sometimes that's short-lived, sometimes it's permanent. The more concerning thing is if we have to remove the entirety of the pituitary, can leave a person with panhypopituitarism, where none of their pituitary hormones are produced. In that case, they need a permanent replacement, and they would need to be under the care of an endocrinologist or a high-end doctor to basically their life. That's not a typical outcome.
With the experience and resources for cases throughout Louisiana, Walters Papillon Thomas Collins, LLC, is proud to support LPB, specializing in personal injury and wrongful death, with information at lawbr.net.